everybody for coming tonight. My name is Tim Willens, and I'm the Chief of Child and Adolescent Psychiatry at Mass General Hospital. And I want to thank you all for being here. This is a real extraordinary subject matter because it is, when you think about it, one of the areas that we really always worry about, but remarkably don't talk about very much. And you'll hear me say this as I go through a little bit further into it. Part of it is there's just not a lot of research in this area, and there's not, for a long time, not a lot of conversation about this. We do a great job with kids, and we do a great job with adults. Well, actually, not such a great job, but whatever. But that interface, when you go from childhood to adulthood, which we all know and worry about in our kids, is really not well mapped out. And it's almost like every kid has to make their own journey, and that means every kid is connected to a family, or hopefully to some family or system. And that parent or parents and family are the ones who are trying to map out a course for that kid. And then it's particularly confounded when there are any kind of problems that you're experiencing, either as a family or the child or a combination. So our hope is today to really sort of at least begin a dialogue about this, talk a little bit about some of the major things that we bump into, and some idea about what are some challenges and what are some solutions to navigating these straits. And that's what we're hoping to do. Some housekeeping first. I think you have booklets, so if you didn't get one of our handy booklets, most of the slides are there, and you're welcome to have those booklets take home. We will have a break around 6-ish, because people are going to get hungry. We have some snacks, and also give you some time to stretch, and if you see some of the faculty members who may have lectured or are going to lecture, to get some questions answered. I also want to thank and shout out some people who are really near and dear to us. Is first of all, this would not be able to do this type of thing without generosity. We have the Joan and Leonard Ingle Foundation. Judith Clifford, who's going to be able to come up in a few minutes and just tell us a little bit and help launch today's educational event. I want to say that Judith has really been at the forefront of really helping us to be able to get out and tell our story in different venues, to be able to do parent education around child health, child psychiatric issues. And really, it's been quite helpful and well attended, and really has made an impact. And a number of families have commented that they found it really quite helpful. And some families who were the first time stepping into this arena said that it helped destigmatize and help them go out and get assistance for their kids. So thank you on behalf of the families who view this, and also ourselves. And thank you for allowing us to do this. And there's others, and I'll sort of point that out as we progress through this terrain. So I would like to introduce Ms. Judith Clifford, who is also, I will say in advance, has walked through this with her own kids, so is a mother and is a philanthropist and a very important person when it comes to our educational endeavors. Thank you for being here and for being willing to speak.
Thank you so much. Okay. I'm delighted to welcome all of you here today. Thank you to all the presenters and support staff that have worked to make this parent and family education program possible. Equally important, I'd like to thank each one of you for being here. As we all know, like every other disease, mental illness does not discriminate. The rich, the poor, the old, and the young, males and females in every ethnic group are all at risk. I do wish, however, that it was considered like every other disease. I have hopes that sometime soon mental illness will be more openly discussed and that those that suffer will not be stigmatized. We are all so fortunate to have the resource of the MGH Child and Adolescent Psych Department to help us and our families navigate through the challenges of this disease. This renowned department is leading the way when it comes to research, educating professionals, reaching out to the community, and most especially caring for their patients. All reasons that I am compelled to support this group. It's been a journey for my family and me, And while I unequivocally can say that I have not enjoyed the many bumps and thumps along the way, I have come to appreciate that the challenges and struggles of dealing with this disease have greatly influenced my life. I am more patient, less judgmental. I am more open and willing to share. I am stronger than I ever imagined, and I have found a passion in life in trying to educate others around me. It is heartening to be surrounded right now by all of you. It is an honor and a privilege to be part of this symposium. Thank you.
And thank you. And with that, if we could have the first set of slides up. I'm going to be navigating, watching that way. So my challenge is to talk us through what are some of the normality and the transitions that kids are undergoing, and what are some of the challenges and bumps, and what are some things that we've learned as we've walked through that. And I'm going to try to put a little bit of research on top of it, some clinical experience, parenting, not so good, but all the rest. So first of all, when we're talking about transitional age youth, you're going to keep hearing that TAY come up. It's just what rather than say transitional age youth all the time, we say TAY. And it's really can be transitional age youth or it could be transitioning adolescents and young adults. It's interesting. We use the word TAY. And then we did sort of a mini focus group and we found they hate being called TAY. Okay, so that's why we're in medicine and not marketing. But nevertheless, when you see TAY, that's what it's referring to. And it's really 15 to 26, 15, you know. And even that's a little bit arbitrary, but we're talking about that period of time. We've been looking at that, and the reason we're really interested, and I'm not going to go through this in all detail because I'm going to touch on that a little bit later, but this is when, you know, there's good data, you're going to see me say that most of the issues that we deal with, a lot of people deal with in adulthood start in childhood. And as we're looking, this is when things are happening. This is when people develop problems and phobias and nervousness and anxiety and depression and whatever else. Or they've carried it from childhood. Or they aren't, and they're just having a tough time. There are a lot of things that are occurring. So just typically when you think about it, there's intense interpersonal relationships during this period of time. Think about first loves, second loves, coming to terms with that. Intense relationships with your parents. Peer influences. Data show, for example, that kids, you always think of adolescents, young adolescents as being peer influence, but it's actually older adolescents and young adults where there's the most influence on the kids. You want to stop somebody, you're going to hear about it, let's say, with substance use a little bit later. You want to stop substance use, you're going to have the kids change their peer groups. You got a peer group that's deviant this direction, your son or daughter is going to be in that direction because that is really intense at that time. There's more sexual experiences and less oversight as the kids get older, of course. If you look at high-risk behaviors, we always think of high-risk behaviors being young adolescents or even younger kids. But if you actually look at charts of that, and they've done that, you see the high-risk behaviors actually starting to go up steeply on that curve around age 15, 16, a little bit gender difference, and then peaking at around 22, 23. So it's our kids who are leaving, who are on their exit from the typical structure home, 18, 19 years of age, that are at risk for the highest risk behaviors. Cigarette and substance use, you're going to hear about driving, right? Driving is when you're starting at 16, 17. L data show that if you look at high-risk driving behaviors, it's actually not 16 and 17, it's closer to 18, 19, 20. And delinquent acts and the problems, again, if you look at, let's say, boys, where you see 3 times the amount of delinquency, and you look at where does that plot out, even though conduct symptoms start early in kids, if you look at the actual behaviors that are delinquent, it's around 22 to 24 years of age. I'm going to hit this a little bit harder, so I'm going to save that. We're going to actually talk about understanding the development of the brain. It really does help understand it. It's a separation and individuation time. So those of you who have kids at home who have left or are leaving the home, if you have them and they're juniors and seniors at home right now, you're saying to yourself, they're aggravating, they're irritating you, And there's a purposeful component of that, and people in our field say that that's sort of what we call the second rapprochement. That is a second separation individuation. The same as a toddler, adolescents are acting the same way. And a lot of people will say, don't act like a toddler. You're acting just like you did when you were a toddler. Irritating, agitating, and a lot of people go, I can't wait. I love my kid, but I can't wait for them to go to the military, to get a job and get out of here, or go to college. I'm booting them out, and they've asked for that. And that is a normal component of separation. I cannot stress enough the stress to parents around legal issues. At 17, if you do the wrong text, sex text, you get slapped. And there could be ramifications, and there probably will be in the school system, but there may not be long-standing legal complications. You do the same thing one day after your birthday on your 18th, and now you can have a long history of different kinds of infractions related to that are now in the legal sphere that don't go away so much. The kids, unfortunately, don't realize that, but you, the parents, do. So there's a tremendous amount of stress around legal. And if I were to say that 50% of the stress that people I work with around this is around, if my kid does this, if they get and do this, if they're doing stupid things, they don't understand the implications. Then there's, of course, the independent academic endeavors such as college and picking the right college. You're going to hear more about that. We have experts on that. But that becomes goodness of fit in college is that. There's a college or an experience. I don't want this just to be about college-age students. This is for people who are leaving independent. An occupation, a college, a trade, a military experience, that's for every kid. But you have to find the right one, and that's going to take a lot of TLC to get there. Occupational independence, that may be their first thing, and it's important to get a good step. And what is it like to be an apprentice? And how hard is it to do that? And what do you need to do? And by the way, most of the occupations now is not just as simple as you show up and do that. If you're in the union, they're going to expect a certain amount of skilled work and that you're going to have to learn and you're going to have to continue to study. Military involvement, for those individuals who have kids who are headed that direction, it's very hard for certain families. It creates its own stress on families. And then we say the beginning of financial independence. I just have to say beginning. I have a kid who's arguing with me right now about his Dunkin' Donuts charge was after I put extra money in his account, and I told him no, it was before, and that's why he got an alert that he went in negative balance and how bad that is. And I think he claims this is going to go to the U.S. Supreme Court before it gets settled, which is another fact of working with this. And then finally, socialization shifts greatly for these kids. Their whole world changes. The peers, I cannot stress enough, their peers are their family. That is their life. So I want to talk about this just briefly, and I just want to make a comment that illness that emerges during this time, and we're a psych program, so you're going to hear more about that, that didn't animate the way it was supposed to. This is like a projective test for what do you think is up there. But what should be up there is that over 50% of all health burden in kids around the world is in the behavioral health realm. Anxiety, depression, alcohol use disorders account for almost half of that. But 50% of all health burden in young people, the age grade we're talking about, is actually up here. It's behavioral health. That's why we're so worried about it and so interested in it. So this just shows you the case of major disorders. This is the disorder starting in childhood. This is the age at onset here. When did it start? And this is the different percentage of who developed what. I just want to show this is just typical what happens. This is childhood onset. This is during the transitional age years, up until mid-20s. And I want to point out that if you look at most disorders that we deal with in adulthood, look when they're starting. And that is kind of take care. That is the kids we're worried about. I just want to show you. This is major depression. This is garden variety depression. Look where it is. Look where it's occurring. Tay onset or transitional age youth. That's when it's happening. Okay, let's look at obsessive-compulsive disorder again. It's starting here and here. That's when most of the cases. These are 3 different studies. That's where it's starting. It's childhood onset, it's that. And yet we talk about it in adulthood, but this is where it starts. When you have, and it goes on, by the way. I could show it for every different disorder. In fact, that was the motivation for our our department to say we need a Tay initiative. We need a special initiative that we connect kids and adults, and we worry about that group, that interface between the two of them. When you have kids who have any kind of behavioral health issues, these are some areas you have to really worry. I think everybody here knows about school and college, tests, examinations, even with accommodations in the schools, which I strongly recommend. You need to find the right college. If your kid needs accommodations, you need to find the right school. And there is a school for your child. There is a school. But you're going to have to accommodate. You're going to hear more about it. Tests are still going to be hard and examinations are still going to be hard. They're still college level. There's expectations. There's homework and a lot of it. And your kid may not be used to that much homework. Occupational independence, again, you don't show up to work, you're fired. You get warning and you're out. It's no longer an easy play, and these kids have problems with tardiness and getting to school. Some of the other ones, for those of you who have kids who are athletes and may make it into sports, that's great. But I work with that, and Dr. Kaneka will be here. He's actually also works with athletics. If they're in college or if they're playing for a minor league team, there's a very complex playbook. It is no longer just street play. It is really complicated, and they have got to be in the game if they're playing that way. They've got to really be on top and understand. There's also a higher level of play. You have to be strict about your practice, and you are expected to do a lot on your own. And a lot of these kids don't get that. They're used to the structure of high school, and when they lose that, that becomes an issue. And then finally, diet. You can't eat crap. You've got to eat good food, and you got to eat a lot of it. And these kids often, I've seen them and I treated them, where they get very thin and they start falling behind because they're not eating and they don't have the self-imposed structure around getting their practices in. I want to comment a little bit because I think this explains an awful lot. It really helps to understand brain development in kids. And that is that if you're looking at this, we know that studies in young adults show the frontal lobes don't really exist until the age of 30. Okay, so it takes a long time to get there. I've been accused that mine are still in development, but it's nevertheless a real issue. The limbic side of your brain develops very early. That is the emotional side of the brain. That is, I want chocolate, I want drugs, I want alcohol, I want sex. I call it the sex, drugs, and rock and roll center of the brain. And that starts early. It's highly influenced by hormones. Ergo, what happened to my kid? My kid was doing great, and the hormones kicked in, and all of a sudden, emotional, etc. That's the emotional or limbic center of the brain. That is controlled by the frontal part of your brain, right here. So the deep emotional centers are here, but if you put your hand over your forehead, that's the emotion. That's the frontal lobes of your brain. That's the part that's keeping you there. You may want to get up and run out and get a snack, but you're sitting here. You may want to say something, but you haven't because this part oversees the emotional center. That's called, by the way, they have a fancy name. It's called top-down approach. Top-down approach. And that usually is operational. But in kids who are growing up, that isn't. There's a dissymmetry between that. That is not fully there until your mid-20s. And most people get that kids they're still really kids until they're in their mid-20s. We also think, so what this is the development of the sex, drugs, and rock and roll center. And this is the development, the slow plodding development of this part of your brain. It's impulse control, one thing after another, the secretary of your brain. This develops, but it takes a long time. And this separation right there, we think, is linked to why we see more substance use and more mood dysregulation, why kids make stupid decisions, and when you say, why did you do that? They go, I don't know. And you know what? The NIH did a study where they actually looked at that, and you know what? They didn't know. They really didn't know. But it does help you understand that symmetry also seems to be even further exaggerated when you have disorders like ADHD, where you don't have as much oversight, or you have a mood disorder where that sex, drugs, and rock and roll center is revved up. We think that's explains an awful lot of adolescent behaviors, why they do certain things. And that, again, that frontal part is not mature until 25 to 30 years of age. We also know that this is a group that there's not a lot of services for them. And we ran into problems. I'm giving a shout out to the MGH here, and I do want to give a shout out, and you're going to hear more about it. We have one of the first what we call TAY clinics, and that was, and I see Margaret Carr back there and the Judith Foundation. It really allowed us to, oh, there you are. That really allowed us to push the envelope and start a clinic that was for this age group. And you're going to hear from some of the faculty members that teach there, because we really never had anything there, and we were concerned of this discontinuity. And it's been helpful. We have a number of programs that service this, but nothing general to take a look at kids and do evaluations and teach the next generation of doctors. And the reason we did that is because when we ask our adult colleagues, what is it about this group that you are reticent to treat, you don't want to step in, they said, if you look all the way to my right, retention, continuity of care in the yellow, that they can't get them to come back for their second visit. They don't come back. Alliance issues. I don't know how to connect with a college kid. I don't know how to connect with a kid who is just out of high school. I feel funny talking to them. I feel like I'm talking to my kid, and I don't know how to deal with them, even though I'm an adult trained person. And then the other one was substance use. I don't really like working with substance use, and I don't understand this binge pattern, which a lot of these kids do, and you'll hear more about. The other issue that we're worried about is not only that, but think about physical health. A lot of these kids, it's important if you have kids this age, to map it out with the pediatrician. How long into this child's years will you continue to see them? The 20s? Most pediatricians, general pediatricians, are actually quite good with 20, 21, 22-year-olds. But when do they transition? And each pediatrician is different, and it's really hard on a family to have a quick transition where the pediatrician says, no longer are you my patient, go find an adult primary care doctor. And then how are you going to find an adult primary care doctor who does geriatrics that's working with your 21-year-old? So those are comments you can have with the pediatric practice in advance to help with that transition. The other is variable insurance coverage. So we have now till 26, but actually that's not the case in a lot of cases. And there's a lot of discontinuity around that if they're going to certain institutions, if they're in the military, if they're college, if they're working in an occupation, which may have less good coverage, but they are obligated to use that coverage. And then if you have a kid who's got chronic issues and they need to go on to one of the public assistance programs. And how do you navigate that at the same time? I think we've already talked about this. This is a big issue, and we're trying to work out to better train our adult residents to take care of that. We think that adult psychiatry and adult behavioral care for kids who may have behavioral health issues is best served by people who are trained on that. So part of the mission of our clinic here, for example, is to train our adult people. But if you're out there looking for who to treat, if you go to I just got a referral. I just got back from Burlington for my own kids are up there, but then somebody I bumped into needed a referral for their own kid up there, and it was the adult people wouldn't touch it. A college student, and I reached out to my child psychiatry friends up there. We know a number of our graduates have been up there, and they were very helpful to find referrals in the area. Very different, by the way. Their system is really quite different than ours. I was shocked. They have nobody who does private pay. It's all by insurance or through systems. So it's really quite different than the Boston system. But for them, I said they need a child, in this case, a child psychologist, not an adult psychologist. These are child-based issues in a 21. There's a 21-year-old, it could be a 16-year-old. And then I think we talked a little bit about that. The other issue we always worry about is the whole issue around the training of the individuals who are seeing it. So if you have kids who are launching and in a different area and getting care from somebody, it's not unreasonable to say, how many kids have you worked with? Is this a disorder or disorders that you're used to? Because some people are used to working with adults, middle-aged adults who have drinking and depression or separation issues in a relationship, not used to working with kids who have ADHD, autism spectrum, and a touch of depression. And it's probably not the right fit for that kid to be in with that adult provider. And I think we think developmentally sensitive approach, that the person understands development, that if you're 21, you have components of a 21-year-old, a 16-year-old, and a 12-year-old. And understand that you can pick up if something is emerging. Things emerge in this age group. So if you have a kid who's doing well, and then something kind of happens, it's helpful to know, does that person know how to identify emerging issues as opposed to they have emerged? You're going to hear more about this. The therapeutic frame is important. So a kid is 18. Legally, they are the captain of their own ship when it comes to making decisions. Yet, I haven't sat across from an 18-year-old who is really capable, fully capable of making those decisions. Engagement with the family is critical. I at least want to hear from the families, and I want them to be part of a treatment if there's more serious issues going on. That needs to be negotiated. Interestingly, with a lot of providers, they just blanket it by saying, I won't deal with the parents. I won't return calls. I won't listen. That's not what you want to hear. At the very least, that clinician needs to be a receptacle to information that you may have as a parent. You may not want to disclose to the parent what you're talking about with the kid, and usually you don't need to. And most parents, almost honestly, don't want to hear it. But what they do want to hear is be sure is, I, as a treater, hear if there's something going on at home. And I think that's important. So it's an important issue that 18-year-old and the treating team realize that all of a sudden you don't hatch at age 18 into adulthood. It is a process, and your parents are there with you during that process. And I think also the last thing I'll say from that is motivational interviewing is a big part of what we do. Getting kids into their first session and getting them back for their second and their third session. There is a huge component if they're using substances to do that, if they're on meds to engage, if they're going for psychotherapy to motivate them to go to psychotherapy. There is a huge salesman component to what you do when you're working with these kids, and that is part of the care. It isn't flashy. It is part of the care. Without it, the kids don't come back. This group will vanish, and that's not a good outcome for anybody. So it's a developmentally vulnerable group. We think that young adult behavioral health issues are the rule, not the exception in terms of when they start. The bad news, there's a paucity of studies. The good news, we're attacking it at our institution, but others are too now. The NIH, for example, is now earmarking special studies for young people. They want to know this population. They've gotten it. And you know what? By the way, you know where that came from? It came from parent groups going to the NIH and demanding that these kids get studied specially. Don't put them into these other studies of 6-year-olds or 50-year-olds. This is a different group. And I was there. And the last thing I would say is stay tuned to learn more about Take Care. Thank you.